Excited to be here with you today and um, take it, Rena. Thank you.
Thanks, Elisa. Hi, everyone. I'm so happy to be with you today. I'm a pediatrician. I wanted to start our experience together with just taking a big breath and settling in with some gratitude. This is pretty remarkable and terrific, the way that the health department, Family and Child Health Division, and the Blueprint are partnering in the space of child health. And I've been around a long time, and I'm really grateful. It is important in our work to acknowledge that we really want to show up a little bit differently in the child family arena, knowing that it is not the same as adult healthcare. And I know you all really know that. And when I look at the list of people who have joined on today, I can feel this really depth of expertise that we're all in sort of a shared learning community today. And that feels really good. Vermont is a remarkable place with a lot of hardworking people, and I count you among them. I did want to also acknowledge that it's not really that easy or joyful to deliver healthcare these days, and that the roles that you're playing in service of the practices and also children and families it really matters. And it's really grateful for your engagement and your ongoing efforts as we're not going to solve all that is not working in healthcare. But what we want to do today and in this series is to start to form a sense of some of the hopefulness and the bright spots and the areas where we really have opportunity. So I'm just so happy to see you all. Quickly, and we're really hoping there's enough time for it's a big group, but we still feel there'll be a nice interactive opportunity. We are very much wanting to talk together about this trust and relationship building that needs to occur in the context of working with families. We all understand the importance of screening, but it is not our intention to do that in the absence of trust. We want you to be very excited and engaged around our Touchpoints approach with that offer, as Elisa pointed out, that if you're inspired today, there'll be an opportunity for Blueprint teams to join the comprehensive Touchpoints training starting in January. And then just a little refresher, this might be new, repeat for a lot of you. What on earth is the Bright Futures Guideline, and how do we use it as a tool in healthcare for children? Okay, we're going to enter into a funny space right now for those that are eating and thinking you're going to be in a oops, something just happened with my audio. Are you good? Okay. I want to do a little bit of the why we're all here today, and then we are going to do a quick breakout session for you to talk to each other about a few prompts about your own observations working with children and families or your own experience as a child in a family. So we can find a lot of quotes along the way, but we want to ground us in this, that if we can get one generation full of deeply loving parents, we can change the brain of the next generation. So this work is not for the faint of heart. This is massive impact, our ability to show up for new babies in the context of a family. I hope all of you saw, and I'm very grateful for the Surgeon General of our country these days. He's taking that role very seriously, and he has decided that parental stress is a public health crisis. And there's the link there. He calls his very long brief Parents Under Pressure. Raising children is sacred work. It should matter to all of us, is his tagline. I couldn't agree more. He's able to use data to show that 41% of parents currently in the United States say most days they're so stressed they can't function. And that compares to 20% of people who are not parenting. And that 48% of parents say that most days their stress is completely overwhelming. And that is compared to 26% of non-parent surveyed. So we have to just sit in this for a second as a group of people who care deeply. That there aren't very many things we measure that are this alarming, at least to me, at a certain stage in my career. And then there's T. Barry Brazelton, who designed and developed the Touchpoints Approach a really long time ago, and died just shy of his 100th birthday in 2018. And he says, when we strengthen families, we strengthen the community. Our goal is parents everywhere work with supportive providers, that they feel confident in their parenting roles, they form strong and resilient attachments to their children. And to achieve this, we must be responsive to those parents. We have to know a little bit about child development, and we have to truly be eager to see that every parent succeeds. So with that in mind, Elisa's going to work a new tech skill, and we're going to send you out. We recognize that it isn't always comfortable in work settings to be thinking about personal experiences. So the prompt here, which does come from Touchpoints, is you can either, as a group, we're going to send you out in groups of 3, I think, or 4. Think about your own family. What's the makeup of your family? What do you want for children? What do you believe about child rearing? And what do you believe in your role is working for children and families? Or you can think about a family that you're working with or have worked with. You're also welcome to think about, a broader context if you've worked in other settings. What is the makeup of families around you? And what do you think other families believe about child rearing? And then what does a family believe your role is? So it's pretty open-ended. We should probably figure out a way to put this in the chat, Elisa, but maybe that's too hard. Pretty informal, no big report out. We're just going to send you out to get us grounded today and why we're all here. And I will pause to see how hard the breakout rooms is.
Brina, how long are they in the breakout rooms?
I think 5 minutes.
Okay, thank you. I'm opening them now. Let's see how it goes.
Looks like we're going to go too, Elisa. That's great.
I think that worked, right, Julie and
I think it looks
Yes,
great.
it looks like it
people
did.
disappeared.
Awesome.
I love that Kara put that in the chat because then I was able to download it and open a separate window too.
So yeah, I think that worked because this is our group. We're in a group.
Yeah.
Okay. We weren't just left behind as stragglers in
No.
the main
I
room.
think we may have been, but we can make a group. But Julie, did you mean to take control of the room?
No.
Okay, I'm gonna
No.
take that back. Take over.
Yeah.
Okay. So I'm gonna close the rooms in 5 minutes.
Okay.
Great.
Great.
Anyone
Hello,
like to
everyone.
start?
Hello.
Um,
What'd you say, Julie, about start?
Oh no, I just said where would we like to start?
I'll be brave. So I make up very small. My parents are both single children, and I don't have children. I have a brother with stepkids and children. For children, I want them to feel like they have a place to be curious, have their needs met, and learn about life, the universe, and everything. Believing about child rearing is extremely difficult, especially in a digital age. And my role in working with families and their children as a quality improvement facilitator as part of the blueprint is helping connect service providers, be they primary care or other, with the evidence base, the resources, and speaking to what Brina brought up in the beginning, kind of the motivation and will that we can, even if it's not easy right now. And so given my space, I don't really think I have anything to speak to kind of in the second chart. So I think I will wrap up there. And why don't I pass to Greg? Are you willing to share now?
Sure. Yeah.
Great.
So currently don't have a nuclear family of my own besides, my parents and everything, but currently engaged. So that's nice.
Congratulations.
I want to try my best to give parents the comfort and confidence to sort of parent in a very digital age now. It's a lot of parenting has been facilitated to online and all these forums that come up, and kids have more information available to them than ever before. And so trying to help navigate, usually with the kids, of like, hey, this is how we should be going about this. And here's some usual societal norms that don't usually get mentioned in these forums, and I think it's really important that you should know these going forward. And so, trying to help navigate between those two settings is really kind of where I find myself. Pass to you, Morgan.
Hi guys, I am so sorry. I was in the meeting and then it kicked me out of the meeting. So I apologize if I'm like in a different meeting that I wasn't supposed to be in, or if I'm joining your group. My name's Morgan. I am one of the social workers and behavioral health clinicians, actually more on the adult team for Blueprint. So I don't work a ton with children. However, I might be a semi-expert in children only because I have a child. No, I'm only joking, but I actually do have a child. But I guess let me answer the questions for you. I do work with families and children, but more on the adult side, just so you know where I'm coming from on my team. We have a pediatric team, we have an adult team, so I'm assigned more to the adult team. But what is the makeup of my own family? So as I said, I have a daughter and a husband, so just one daughter, but I have two sisters and they have children, so lots of children running around in our family. Thinking about our own family, what do you want for children? So what do I want for my own child and her friends and my nieces and nephew? I do believe in safety. I believe in them having a voice, and I do believe in being an advocate for children. So I'm huge on that. Whether it's in the healthcare system or whatever system you want to be into, I do feel that we should be advocates for children, but allowing them to have their own voice, I think, is incredibly important, and having them part of conversations. I think in previous lives or previous decades, people spoke for children instead of having them at the table and having them at the conversation. So we're learning that now. Regarding, again, continuing on with conversations, what do you believe about child rearing? I do believe in positive parenting and positive interactions for children. So I try to be more of like a yes mom versus a no mom. So I do believe in kind of that Montessori approach. Then you get kind of further with kids, again, having them at the table and kind of letting go of like the negative interactions. So if you can instill like values and hopes, and again, being a good example, I think can go a long way. Listening is huge for all of us. So listening to actually what they actually have to say versus telling kids. I think in previous conversations, kids were supposed to be heard versus being part of the conversation. So for time, I'll keep going. What do you believe is your role with in working with children and or with families and their children? Again, I kind of am on this entire method of having them at the table. So whether that is a child or their families, if I'm treating more of their adults, I think we can't treat adults without treating children, and we can't treat children without treating adults. You have to treat kind of the entire family unless it's one single person. So that's kind of my take on everything, is treating the entire family. If it is family, if it's just one individual, that's a different story here. But treating everybody together as the unilateral family. So that's what I got for you guys. If you want me to, am I supposed to answer the second question? Because I know I jumped in halfway on this. Or was that it? Are we only doing the first part?
You could
Yeah, and I
pick.
think we're gonna get bounced back to the main room now, which is
Okay,
totally
sorry,
fine. Yeah,
guys.
that's totally fine.
Awesome. Well, this
Thank
was
you
great.
all.
Yeah,
Thank
thanks.
you.
Do we have a small group? Is that what it was? I didn't even get to see everybody in here, so I am so sorry.
That's fine. I think we
Okay.
probably had the same size group as some others. It was
Okay.
funny, some folks came in later, but it was very effective. So this was nice. It gave me some new concepts to think about from hearing multiple people share.
Seconds. All right, nice chatting.
Thank you.
Okay, Elisa, nice work. Oh, I got the echo again. Okay. Is everybody back? Elisa, can you tell? 47 people, close
I
enough?
think, yeah, I think so.
Okay. Okay,
We
we're
did
not
okay.
going to debrief. I promise we're not going to call anybody out, but if anyone wants to unmute and share what that was like, we created a little space here for that. It was fun that I actually went out into a breakout that so usually the presenters stay behind.
This is Thomasina with the facilitator with the blueprint. I just think I'll be interested to see kind of what concepts came up from just each small breakout group that then gets echoed in what you guys share. So I'll be looking for some keywords that I took down while everyone was sharing.
Ooh, I love that. Yeah, let's see how that rolls because I appreciate your willingness to do that. We did have a little we wondered ahead of time, we come in at a lunch and learn hoping for some passivity and breakouts can create a little anxiety. So thank you.
Hi.
Okay.
Oh, sorry.
Go ahead. No, go ahead.
I'm Lori Burnett. I'm here in St. Albans at a pediatric practice. And I've always worked with children, youth, and families. And the breakout was one of the easier ones I've ever had over the years. The three of us are in this for the youth. And we talked about self-care a little bit because sometimes I am not as invested and I realize that I need a break from parents. I work with parents and children, primarily the children. But it's the self-care. I used to get sick of hearing about it when I was with big agencies. And I realized to do the best that I can do to help the parents do the best that they can do, taking good care of ourselves, whether we have little ones at home or not, and just staying invested, not giving up is what I got from our people.
Wonderful. Thanks for sharing that. It's a really nice way to head into some of this shared content. So I think a lot of you have come along to understanding how some communities do have this Dulce approach. We wanted to make sure that those that haven't heard about it just had a little bit of a background on what we're attempting to do here in the great state of Vermont. So Dulce is developmental understanding and legal collaboration for everyone. And it's really about relationships, and it's about the earliest relationships because it's just for babies. Although we really like the concepts and use them with all ages. So what we're trying to do here is by attending to the relationship between parent and provider and parent and child, we're building the social emotional competence of these children, and we're actually trying to change society. I know that sounds hyperbolic, but it's true. And the through line here is that the training for the family specialists who do this work is Touchpoints. So we're in alignment there. It's intentional that it's only for babies for a lot of reasons, most of which you know about brain architecture and early opportunity. And the most important thing for all of us to settle into this afternoon is this is not an educational model or approach where we sit in a room and we teach parents how to parent. It's about developing healthy relationships to stay in a strength space and to wondering about a parent's experience without risk that they are going to feel they're not measuring up. And the reason it's so important to talk to my healthcare colleagues about this is because we really overemphasize and love to measure our success on screening, because healthcare has really been recognized over the years as an important place to ask a lot of questions. And that's really evolved over the last 30 years. And in that screening, we want to make a very important point today that when you're with children and families, screening in the absence of a relationship is unethical because it sets people up for feeling worse about themselves and also for feeling that it's a not safe space for them to talk. Because if you feel like every time you enter into a setting, you're going to be asked about everything that you're not providing for your child, it's a very hard place to build trust. So Dulce's done a lot of, there's a lot of national research about this and evaluation, but I've just pulled out this one study to remind us that over the years, we've done a lot of deciding as healthcare people who we're going to ask about what. And I know that we all know this, but this study grounds us in the notion that if we look at certain indicators as a way that we're going to identify families who need us and need intervention, we're going to miss 75% of the people, of the needs of children and families in this system. And what I mean by that is over the years, we've thought we needed to do more intensive screening of people based on poverty, whether it's their first time parenting, how old they are when they have a child, and whether they've already had child welfare involvement. And this study demonstrated that the system intended to support families with infants in those low resource communities actually missed the 75% of people by using those 4 indicators. So we can say this a lot of different ways, but it just really, really emphasizes the importance of universality, which I really think you're doing, but you might catch yourself sometimes thinking of a family that shows up a certain way doesn't need the same level of screen or trust or relationship building as others. So that's why we love Dulce, but we also love the work the Blueprint's doing. So this term is new. Do you guys love in a career how there's work and efforts and people keep rebranding it and naming it something different? And so if you haven't heard this term, it's not because you missed anything. This is a relatively new way to talk about 2-generation focus. And it's the recognition that parent-child attachment and the development of that relationship is actually should be in the center of our work, that we're really in service of promoting the relationship between us and parent, but also parent and child. So it's got some really nice equity principles to it, and it's been really studied in science, which I know you all follow, that when people feel a relationship with their child, it's protective for child abuse. And when they feel a relationship with their provider, it's also protective for parental stress. So we're in kind of a win-win here when we attend to relationships. And not surprising, we still struggle with this in our system because we have parent-focused things we're doing, and we always wonder what's going on with parent. And then we obviously, most of us are in service of what's going on with children. And what we're trying to do here is help the system to integrate those two things. And when we say we're in dyadic work or working with parent-child, you'll still see that payment or effort or program aligns with one side of that dyad. It's a very big lift to actually work with a whole family, which is why parent-child centers are incredible. And parent-child centers were the brainchild of Vermonters in the 70s and 80s, where they said this is not working to hold these two systems separate, and they put them together in every community in Vermont. And you're going to hear more about them and their efforts on the early childhood front in our next session together in October. Okay, let's dive into Bright Futures for a sec. We love to make the observation here that there's some confusion in this language. So Bright Futures is the preventive guideline for the care of infant, children, and youth and families for the country. But the Building Bright Futures is a state and regional council system for early childhood. And if you are really savvy, you'll know that the data collection system for childcare in the great state of Vermont is called the Bright Futures Information System. So if you feel confused about the term Bright Futures, you're in good company. We are very attached to Bright Futures Preventive Service Guideline in Vermont because the editors for the country of this tome are all Vermont people. Paula Duncan, Joe Hagan, and Judy Shaw, who used to run VCHIP. Pretty crazy. So have you seen this? There it is. This is the set of principles, strategies, tools that we've worked so hard on nationally to make sure that there's some sort of standard. Most of my pediatric and family medicine colleagues aspire to this, but also acknowledge it's dense and thick and hard. So the space of understanding the difference between aspiration and how the day unfolds and unravels is really a space I know you all hold as blueprint teams. It's okay though, because having a place where we can hold ourselves to standard is a nice North Star for people because we all seek to do such high quality work. The other part of Vermont that's cool is our Medicaid program adopts this as the standard of care. That's not true in every state. So to be a provider in our system who is in our Medicaid program, you are asked to follow Bright Futures. And then there's this crazy thing called EPSDT, which a lot of people wish had a catchier title. So when it was determined in the 1960s that children who had less economic opportunity needed health insurance, we designed, not me, I was barely born, but we created health insurance for children, Medicaid. But 2 years later, the federal government got back together and said that wasn't enough because all that did was risk that children with less economic opportunity would have substandard care because there was no standard of what Medicaid insurance had to pay for. So they developed EPSDT, which stands for Early Periodic Screening, Diagnosis, and Treatment. If you want to be part of Vermont's history, our wonderful colleague at the health department, Gary Shadle, created a PowerPoint that said, every president should destroy the tapes, which was a callback to how to remember that the P's before the S, the D, and the T. And it was because when this finally was codified in state Medicaid, it was during the Nixon administration. So I don't see many of your faces to know how old you are, and I'm not going to pretend to know, but that helped me get the S, D, and T in the right order early on. But this is very important, fundamental, foundational work to how Vermont shows up. This is us saying that there has to be a program around the payment of just the service, and that we absolutely are required in our state to provide comprehensive preventive care for all children, and that it has to be covered. And this would be a whole other talk, but we like the grounding principle of it because our health department uses this as a strategy for investment in things that matter in the care of children. And then the part that we can use humor about is because we love this book, and one of our great colleagues, Nathaniel Waite, has this on the wall. This is what's called the periodicity schedule. This is what you're supposed to do at every well child check. And I know you live this every day with your teams. I just want to acknowledge that the only way to get this done is with a system of care and with support teams like you all provide. We can't put this all on just the provider. So I'm very passionate about team-based care. Okay, the cool part about Bright Futures was, and this is old news now, when it came out in its 4th edition in 2017, it acknowledged that it was a pediatrician's role to address health-related social needs. And if some of you are new or younger, you think, well, that's been in the vernacular and in our world for a long time, but it really wasn't. It was certainly well known to pediatric healthcare professionals that there was a lot going on with families that we would like to know and address, but this codified it as part of the approach. And that really made us, it did 2 things in Vermont in 2017. One, it woke us up to the idea that you cannot provide healthcare for children without integrated partnerships with your community teams. How on earth are you supposed to solve everything that you're going to ask and find out about without blueprint, without bridges to your community mental health teams, without your early childhood experts? So we're very happy in Vermont that we're using healthcare settings like medical homes as the venue for the connections. So this is a slide to just remind you that you're really in the right place to improve the lives of children and families. But once you're in that place, how you show up is the whole point of this conversation today. This slide used to say that it's not stigmatizing to go to the doctor, which makes this the right place to address social needs. I changed it because we have had to wake up to the fact that it's actually not always safe and welcoming for people to go to healthcare. So seeking medical care may have less stigma for families, it may not. But there are studies that show there's a high level of trust that families feel with their child healthcare professionals. So we can hold both of those things together. Quickly go through, I love Bright Futures because it gets us back to a feeling of order and sort of how am I going to even begin? And the answer is you're going to do this in every checkup with some system. I promise you this is not all verbal, and I know that visits are getting shorter, but the idea that you have to know what is going on with families and there's a screening and immunization component, it's all in the book. Okay, now let's get to the fun part about relationships. So we have in Vermont in the last several years, we've actually been working in the space of touch points for 30 years, but we have had trouble sustaining it as our language of how we show up for families until the last couple of years, thanks to the health department's energy and funding. And now VCHIP, where I work, the Vermont Child Health Improvement Program, is a hub now for touch points for Vermont. And the reason is because we feel so deeply that the work in healthcare and our communities to understand child development and to get everyone screened and to really work in a space of early detection, that we only want to do that in the context of supportive relationships. All development happens in the context of a relationship. So you are going to be hearing, if you haven't already heard, you're going to be hearing more and more. I always liked in big groups to say, and I know I miss people on this slide, but we stand on the shoulders of each other in this state so deeply. And many of you have had other roles over time, and we all got trained in touch points in 2003. I wish I could see more of your faces to say, did anyone go to Bread Loaf in May of 2003? Because that's where I was trained in touch points with Paula Duncan, Cheryl Mitchell, and Jody Brakely. And I came away from that experience thinking this will change the way I practice medicine. And I worked hard on it for several years. And then it sort of fades because you don't have the refreshers, you don't have the community around you talking the same language. And you also, healthcare kind of catches up with you in weird ways where you have all this intention and then the day just, whew. So when I got over, I was at the health department from 2010 until 2020. And during that decade, we had an opportunity to bring Touchpoints back, which we did through this launch grant. But most of you have never heard of the launch grant because it was only in Chittenden County. And it stood for Linking Action for the Unmet Needs in Children's Health. And in that setting, we were psyched. We knew relationships mattered and we got going, but I really shout out to Laura Pentonrider on this call. She tried to tell me we needed sustainable funding for this, and we just never got there. And it went away again. Winston Prouty in Brattleboro, thanks to Chloe and Mary, held on to it and never let it die. It stayed as a little seed. And then we got some good funding from the Preschool Development Grant, and we're back on track. And if I missed anyone, and I know I did, their names can be shared with me and we can keep talking about the history. But now we have this hub. And the facilitators for Touchpoints in Vermont are at the health department. They're over with us at VCHIP, and we have a few of our community leaders, including Chloe, who have stayed on the facilitation team. And we've been able to get into the Northern Lights system, which is the child care professional development system for Vermont. So a little word about what we do over at VCHIP. So we're what we call an improvement partnership. I think we like to, we're in strategic planning and we've sort of changed the way we talk about this a little, but I do want folks to know that we have been around for 25 years. We work in the space of measurement and system approach, but really at our heart, we are quality improvement. And what we're offering here in the early relational health space is the recognition that a lot of you are doing this already, but that if there's a little bit of a paradigm shift that we can do that's actually going to improve our ability to deliver healthcare to children and families, then we're all in. And we have tons of partners, and there's a lot more to say about VCHIP, but I think most of you know who we are. So we took the Touchpoints language out of Boston, and we thought about how we want to talk about it in Vermont, and we got a lot of input, and this is long, but I'm going to read it anyway because it matters so much to me. So Touchpoints is a way that early childhood professionals can engage in relationship with families joining their system of care with a lens that identifies strengths and helps them build their own capacity to parent in response to their child. We are not asking them to come over to us into healthcare or into childcare or into our early childhood system. We meet them over there. Touchpoints helps professionals understand we don't need to have all the answers. In fact, we shouldn't. And that we are bringing expertise. We definitely know stuff. We want to partner with families, but we have to learn what the family's expertise is and what they're experiencing. Then we create shared meaning about who this child is. And there's so much more to say, but it is really a shift. At the base of Touchpoints, we're trying to optimize child development. Well, aren't we all? But we're trying to do it recognizing that the health of a family is paramount, that we ourselves stay healthy. I was so glad that our person came out of breakout and talked about ourselves and self-care. We have to take care of our own side of this equation so that we show up a certain way for families. And this really does strengthen communities because, as you know, parents are not well. And when parents aren't well, a community really struggles. So you all know about Jack Shonkoff. He continues to remind us that everything we talk about today can be used with all children and families, but it's okay to have a bit of an imperative about the first years. That's okay. We don't have to say, infants should be paired against adolescents. They all matter. But young children's development, those early emotional experiences are the architecture of their brain. And we only have 5,000 babies born a year in the state of Vermont. And imagine a world where all 5,000 of those babies had what they needed from their parents. So we've got some systems theory here with Touchpoints. We are deeply rooted in culture. And what we mean by culture is a little different. We'll talk about that in a second. And then the reflective practice, I know, will really resonate with you all. It's the idea that none of us get good at things without reflecting, slowing down, talking to each other. So every time you enter into a room in a medical setting, because most of you are in medical settings, there's a child, there's a caregiver parent, one or the other or both, and then there's us. And it's an ecosystem, and each of those relationships needs attention. Sometimes we do great with a parent while the child is off to the side. Sometimes we're relating well to a child, the parent is not engaged. And sometimes the parent and child are doing well and we're not really part of that. And what Brazelton used to talk about is the ultimate goal is that the parent-child is the strongest of this ecosystem, which we don't really say out loud very often because we're so invested in our role. But we have a very small role, an important one, but it's small. So the cultural piece of Touchpoints is not about necessarily where is a person from, what is their ancestry. It's what we just took you through in the breakout room. What do you believe about parenting? That we spend so little time wondering that with parents. People have beliefs about how a child should fit into their family, how a person should act, and how to parent. And we don't know that by our standard approaches. So Touchpoints are the tools to connect to families in respecting what they're bringing and what we're bringing to the interaction, because we all do. We have bias and we wonder about things that parents are doing all the time. So it's this recognition of historic norms in parenting. I loved multi-generational teams because, boy, have we shifted in how children and families show up. And we have a lot to unpack when we're carrying our own experience and we're working with families. So what we're trying to do, as I already said, we're trying to shift us, especially in healthcare, out of this notion that everyone has to fit our system and join the family in their culture and come alongside them. And that will be the richness of the experience for parenting. And we already talked about reflective practice. Okay, 2 things to hold at once. We care deeply about child development. Many of us know a ton about it. You're all in your practices and you're wondering about screening and feeding back to families over and over again what to expect and what's going on in this pretty predictable trajectory of a child's neurologic development as it relates to the early years. What it looks like and how it impacts the people around them is a little bit of the shift to touch points. We make a lot of assumptions that when kids sit and stand and walk, that's awesome. Slow down and ask parents what that's like for them before assuming that it's some joyful thing. And then all we want you to come away from today is the idea that all of that occurs in the context of a relationship. And Touchpoints offers the skills and strategies to help us support and scaffold all the relationships in that grid, or not grid, that ecosystem: parent-child, parent-caregiver, provider, provider-child. So the official, some of you that have read Brazelton's books and you've seen all the parenting guides, that's about that as you come through normal development, you regress. Not in the pathologic definition of regression, the normal regressions that occur as children are developing. But what we don't talk enough about is how disruptive and disorganizing that is for parents to have a child regress. So touch points are the times when we have predictable developmental stages where children are going to be doing their normal regression as they burst toward their next phase. But we are going to come along and acknowledge for parents that they have ambivalence, disorganization, and that it's a very difficult time for them. So that's the predictable period that leads to the disorganization. Most of the parental frustration and the doubt about what they're doing comes during these disruptions. People start to get a little rhythm with parenting, especially in the early years where they figure some stuff out. And just when they do is when the next touch point comes and a child regresses, has a burst, and then all of that gets thrown back and parents experience frustration. And those periods of time are very high risk. They're high risk for child abuse, but they're also high risk for just parental mismatch, where the kid and the parent lose their attachment because it's so disorganizing. So Touchpoint is the opportunity for us to come along and say, here we go. Your child is heading toward a regression, and it's going to be predictable, and I'm wondering what it's like for you. The collaboration between you and the parent is key here. And that's when we start to really allow parents to speak about their experience and to show they do have strengths and that they're not all disrupted, but that they also have something to offer in that experience rather than being told from us. So just a couple things about the language around touch points, because we're really just teasing this for you because we want you to come into our longer training where we really dive into this. This word assumption is one of there's a primary set of tools in touch points called assumptions, which to me is a pretty negative word, right? You're not supposed to assume stuff, but in touch points, it means, what is your attitude as a provider when you wake up in the morning and you're going to go work with a family? And I'll show you what those are. And then the principles are these relationship strategies we use when we're working with a family and we hit a patch and we think, I'm going to pull out one of my principles from your toolkit. So look at these assumptions. These are the wake up in the morning, I work with families, I'm washing my hair in the shower. I am going to believe today that a parent is an expert in their own child. They don't have to prove it to me. I'm not going to have to look for evidence of it. I'm going to choose to believe it as my attitude. All parents have strengths. How about every parent wants to do well by their child? That one is particularly hard for people who work in child welfare, but it's essential in Touchpoints. Do we really believe all parents want to do well by their child? Try it. Try it on when you enter into a room, and you will see that it attends to the relationship between you and that parent. All parents have something critical to share. Everyone is ambivalent. How beautiful would that be if we could talk to each other about the fact that we don't always love parenting, that today wasn't a good day, and that we're going to try again tomorrow, but that I don't have to fake it with my providers because I'm afraid they're going to think I'm a terrible parent because I'm having a pretty crummy day. The ambivalence of parenting needs to come. That would eliminate that parental stress that the Surgeon General is talking about. How about if you woke up every morning and said, I think parenting is rooted in the cultural belief, and I'm going to just live that today. I'm going to let these people give their kids candy for breakfast because it's their culture and that's what they want to do. That's a pretty hyperbolic example, but. And how about the fact parenting's trial and error? That you do try some stuff, it didn't really work, and there is no answer today. When we come alongside parents and tell them how to toilet train and give them a long lecture on why they should be weaning or that they should, have different practices around behavior and emotional regulation, that's okay. That's one aspect of our job, but it isn't Touchpoints. What Touchpoints is saying, before you go into that, why don't you wonder with a parent what they've tried, what they wonder about, and what they want to do before we give them our lecture series on Parenting 101. And then we put in, Touchpoints has provider assumptions so that we can attend to our workforce and so that we can remember that we're people too and that we are experts in certain aspects of this. And we want to do well and be competent. We also need support, and we have our own culture because we're people and we're in that ecosystem. And then we definitely need to reflect on our own contributions because that's the reflective practice. Okay, we're almost done. Those are the attitudes that you pick. And the joke is the shower, but it's really kind of the beginning of the paradigm shift is to say, this is how I'm going to show up today. The principles are different. The principles and Touchpoints are actually tools for the relationship. So you wake up again, or you're entering the room and you say, I'm going to go to the child and use his behavior as my language for talking. So I'm going to say, did you look at the way your baby just turned and looked at your face when you were talking? And then you leave it there and you pause. And I guarantee you, if you say that, the parent will relax their shoulders and smile. The child turned to the parent's voice, and all you did was observe the behavior. We need to recognize what we bring to interactions. We need to respect culture. This has all been said. Always look for opportunities to support the mastery of parents so that they leave their encounter with you feeling better, not judged or not screened in a way that left them feeling defeated, that they don't have what they need for this child. Something has to support their mastery. You've got a lot of opportunity to focus on the parent with the child. There's a lot of strong reactions that occur in healthcare settings from parents. That's passion. Figuring out a way to value that and not personalize it. Allowing that this is messy, chaotic work. And then I know you already all do this, but this was important to Brazelton in the early days to go beyond your traditional role. And you can picture in the old days, healthcare was very boundaried. There wasn't a lot of that. I'll just give you a ride home, or why don't I just give you a pack of diapers that I bought because we'll figure it out tomorrow kind of thing. That stuff's better now, but we used to have too many boundaries. Okay. Summing it all up, there's a fair amount of healthcare and approach with families that's deficit driven. We're trying to get us into more of a positive space. Some people still believe development is a predictable arc. It is not. It's zigzag, fits and starts, and a lot of dimensions. We've had a little bit of a history, especially in healthcare, of prescriptive language, telling people what they should and shouldn't do. How about the collaborative space you're all working on? We certainly can come in with a little bit of objectivity, but attending to our relationship with parents in an empathic way is the paradigm shift. And then understanding that how we show up can be seen as very restrictive and strict to families, and that the flexibility that we're seeking is in better service of their attachment to us and also to their children. Okay, so that was supposed to pique your interest. And now your great leadership, Elisa and Julie and Mara and others are offering that for 22 participants, you can join us on Wednesdays through January and February. A difficult time in our great state of Vermont, so it will be fun to be together. And this is a big training, but this particular one has a lot of asynchronous opportunity where you can digest content and do some reflecting on your own time, and then come together every week for 90 minutes to work with the group on how we do this together. It's very interactive, a lot of breakout sessions, and a lot of opportunity to practice. I think that's me. Tons of resources. And I really want you to be in touch with me. This is you can hopefully hear it in my voice. This is pretty important work. And I feel it could have helped me stay in pediatric practice if I had a little bit more attention to this joy. There's a lot of joy when you show up for parents in a certain way, both for you, but in the way that parents respond to that kind of attention. Back to Elisa. Thank you.
Thanks, Brina. That was great. So we have a good amount of time. So the only thing left we have formally is the evaluation. So I think I'm going to pull down the slides and then open it up for conversation, discussion, questions, all of that.